HOCM, hypertrophic obstructive cardiomyopathy. Definition wise, genetic myocardial disorder characterized by left or right ventricular hypertrophy, symptomatic more when it occurs on left side. That is usually but not always asymmetric and is associated with microscopic evidence of myocardial fiber, disarray and fibrosis. એટલે hypertrophy भी છે અને myocardial fiber भी disarray with fibrosis જોવા મળે છે in hypertrophic cardiomyopathy. Prevalence 1 in 500, but nowadays newer data suggests that 1 in 300 thing which is due to more aggressively screening of general population. Male is to female equal preponderance, and females are usually detected on later stage. Most common cause of sudden cardiac death in youngsters. History, it was in 1952, first reported in a family in UK where 3 siblings out of 9 siblings had HCM and died suddenly. By the 1960, HCM was the cause. After autopsy and things, people came to know there is an entity called HCM. And the concept of anterior mitral leaflet contributing to this disease came in 1964. By the 1970, doctors came to know about that asymmetric septal hypertrophy and subaortic systolic anterior motion. Both were which were thought to be specific for HCM, were not specific of HCM, but they can exist individually also.
What was the earlier name given to HOCM? It's called IHSS. What is that?
Subaortic stenosis.
Idiopathic hypertrophic
Yes.
subaortic
Yes.
ત્યારે આપણી બુકમાં આવતો પછી
change So it is autosomal dominant, and these are 2 variants, MYH7 and MYBPC3 variants, which are common. These are genetic variants of sarcomere, cardiac muscle. So the screening of first degree relative is required if you get a patient with this disease. So cardiomyopathies, different types of cardiomyopathies exist. Like this is the first images of a normal heart. Second is of hypertrophic cardiomyopathy, in which the septum is having hypertrophy, thickened septum, and that is the image of dilated cardiomyopathy, in which the sarcomeres are dilated in a series pattern. There is dilatation of the LV. Then there is one more entity called left ventricular compaction, non-compaction, in which there is asymmetric hypertrophy, and the fourth is arrhythmogenic cardiomyopathy. But more commoner are HCM and dilated DCM. It is just a slide to show the variation of sarcomeres in each and every this thing. In normally, which is in the mid part, the sarcomeres exist in series. In eccentric hypertrophy, they are elongated, eccentric or dilated cardiomyopathy. And in concentric hypertrophy, that is HOCM, they are added in parallel. So the thickness of the muscle increases, the septum and the free wall. Different types of cardiomyopathy and what problems exist in that. Dilated cardiomyopathy are bad at systole. The contraction is poor. Hypertrophic cardiomyopathy are bad at diastole. That means that there is incomplete filling of the heart. Heart is not able to relax properly due to the dense muscle fibers in the LV. So the types are IHSS, like I suggested, ASH and HOCM. Then there is restrictive cardiomyopathy. It is a form of cardiomyopathy in the fibers develop a lot of fibrosis. Sarcomeres develop a lot of fibrosis. So these are also bad at diastole. It is not to be confused with constrictive cardiomyopathy. It is a different thing. Then there is Fakotsubo cardiomyopathy, stress-induced ballooning of LV, and there is one chemically induced cardiomyopathy. The causes are listed: alcohol, cocaine, amphetamine.
Writing કોણ છે?
Sir, આ એક સ્લાઇડ મને નેટ પરથી મળી.
આ
સારી લાગે તો એને લીધી.
Handwriting બહુ fine છે.
So HCM, thickened muscles, stiffening and scar tissues are present. They cause the inadequate dilatation, diastole of the LV, so incomplete filling. Clinical presentation, can present at any age, any sex, but more common in early adult. Symptoms are dyspnea, syncope, and angina. Arrhythmia can also occur as a symptom. People present first time with arrhythmia also. Diagnostic approach, echo and exercise provocation echo, then cardiac MRI to rule out other causes of fibrosis. In echo, hallmarks to look out are asymmetric septal hypertrophy, systolic entry motion of mitral valve, and LVOT gradients and decreased LV filling. These all parameters can cause increase in the LVOT gradients when we provoke the patient for some exercise like hand fist exercise or standing up from sitting position. At that time, the septum LVOT gradients increase because of the inadequate filling. And in squatting position, due to decreased venous return, the LVOT filling up increases from the LA, so it decreases the symptom. So, HOCM is a form of dynamic obstructive cardiomyopathy. It is not continuously. The septum is a mobile thing, and it also, the filling of LV is dependent upon the LA and filling of the LV. If you increase the venous return, the symptoms will decrease. So, if the patient is dehydrated or doing vigorous exercise or increase in the heart rate, then the symptoms will increase. HOCM symptoms will increase. So,
which important parameter on echo you wish here?
Sorry, sir?
Which important parameter on echo you wish? Which is very sensitive to detect.
Septal thickness.
Thickness, of course, the obvious step, and GLS. Global longitudinal strain. Cardiologist ने cover that. GLS will give you a good idea about early septum thickness.
So the diagnostic pathways, we can go with the symptoms, then family history, physical examination, murmur is present, crescendo, decrescendo murmur. That can be exaggerated by telling the patient to do some exercise or standing up or Valsalva maneuver. Things that decrease the LA filling will increase the murmur in them. EKG will show LVH depolarization, excess deviation. So echo findings are also important. Echo findings, there will be LVH more than 15 mm septal thickness in absence of any other cause of hypertrophy, and more than 13 mm in presence of family history, then we can say that patient will be having HOCM. Medical management, first beta blocker, verapamil and diltiazem, second option. Third option is diazopyramide, but the use of diazopyramide is gradually decreasing because of the side effect profile. It causes dry mouth, constipation, posterdism, frequent intubation. And the newer upcoming, which has come from 2022, it is approved in FDA, is myosin inhibitors. It's called mavacamten. It is available in India also now. In 2025, from October 2025, it is available in India. Calcium channel blockers are of two types, dihydropyrimidine types and non-dihydropyrimidine types. So in calcium channel blockers, the effect of non-DHP, non-dihydropyrimidines is found to be effective. And in fact, the calcium channel blockers which are dihydropyridine types, they are worsening the scenario because they increase the heart rate and cause more of the obstruction of HOCM. So the use of verapamil and diltiazem is recommended. Now, how much obstruction is enough? Obstructive HCM with peak gradient, LVOT gradient more than 30 can be considered, patient can be considered having HCM and can be regularly followed. And the patient who is having symptoms, the symptoms will increase with the peak gradient of 50 or more than 50. In these cases, we would like to provide some intervention besides the medical therapy. So obstruction is a dynamic obstruction. It gets worse if there is vigorous contraction, increase in the heart rate, decreased peripheral vascular resistance, decreased volume in the body, or decreased LA filling. These all will cause decreased filling of the LV and more resistance from LV to emptying of the LV, and will increase the murmur and increase the symptoms. increase heart rate. Indications for therapy, no symptoms, no therapy. We are yet to identify some disease modifying treatment which are not available yet. Symptoms, dyspnea, angina, exertion, we have to rule out is there any obstruction or not. If there is no obstruction, then we can carry out all the beta blocker, diuretics and calcium channel blocker for decongestion. That means we are ruling out HOCM, there is no obstruction, so we can give them diuretics also in case of heart failure management. But if there is obstruction, there is a asymmetric septal hypertrophy which is causing obstruction, then volume depletion should be avoided. Rather, volume filling is required. Patient can be encouraged to drink more water. Vasodilators should be avoided because they will increase heart rate. So, to avoid our angiotensin receptor blockers, ACE inhibitors, nitrates and dihydropyridine types calcium channel blocker. Where the treatment of non-obstructive HOCM or non-obstructive angina or exertion should be calcium channel blocker, but in this case when there is obstruction we have to avoid dihydropyridine types and PDE5 inhibitors. Medical therapy has calcium channel blocker also, but these are diltiazem and verapamil, not the other amlodipine and other parts. Diazopyramide, the use of diazopyramide is decreasing as we saw earlier. We have to be cautious for diuretics in HOCM because it will decrease the volume and increase the symptoms rather more. Then the symptoms, if they are reflective, then we can go for septal reduction therapy, myectomy or alcohol septal ablation.
Students, हमारा माटे questions. What is the maximum dose of this beta blockers in HOCM? I am talking about metoprolol. What is the maximum dose can you give?
400 milligram.
200 तो सब देता मैं आगे बढ़ा
400 up to 400 milligram.
Metoprolol, no? Bisoprolol.
Metoprolol. Yes.
Bisoprolol more than less than 20.
Metoprolol no maximum 400.
If patient can tolerate. We need to titrate it.
because get
એની પહેલા મોસ્ટલી બીજું કોઈ આપણે ઓફર કરી દઈએ કે સીસીબી ઓફ ચાલુ
most of the time you end the duty maybe 50 or 100, not more than main routine cases. In this you know
સડન કાર્ડિક ડેથ બી છે જેને અને બ્રેડીકાર્ડિયા બી થઈ જાય ને ખબર નહીં
સેટિવેટેડ વર્સાટાનો બી આપણે કહીએ છીએ 100 સુધી 100 આરટીબી
યસ યસ 50 mg હાફ બીડી માં મોસ્ટલી અચીવ
હાઇપોટેન્શન
So indications for invasive septal reduction therapy when medically refractory symptoms and if the gradients are still more than 50 mmHg, resting or provoked. So
usual follow-up, see, usual follow-up is 6 months, 1 year. What is the usual follow-up?
yes sir, after 4 weeks, then 2 months, then 6 months, एक follow-up तो करता रहना पड़ेगा with echo and drug કેટલું response symptomatic. જે રીતનું પેલું કેન્ઝિયોસ નામથી માયોકેમ્પટન મળે છે એમાં એ લોકો એવું સજેસ્ટ કર્યું છે કે આ રીતનું ફોલોઅપ હોવું જોઈએ તો ઓબ્વિયસલી એની સાથે આપણે એ રીતે ફોલોઅપ કરવું જોઈએ કેન્ઝિયોસ ઇઝ લાઈક ન્યુઅર ડ્રગ તો એની સાથે દે રિકમેન્ડેડ કે 1 month 4 month 4 weeks એ રીતે ફોલોઅપ કીધું છે So things favoring myectomy, extensive LVH, having intrinsic mitral valve disease, patient having other surgical issues like coronary artery disease and available expertise. Now things favoring
1970 ને 1995 લખ્યું છે એ કોઈ સ્ટડીનો પાર્ટના
part છે favor ablation are suitable coronary anatomy. There should be the feeder, adequate feeder available for the muscle that we are aiming for and available expertise. And obviously patient preference. New that is coming up is mavacamten. We discussed myosin inhibitor. Basically, we'll see the mechanism of action also. Approved in 2022, April 2022 in this thing, US FDA. It is called an orphan drug. Orphan drug is basically something which has very limited patient population to cater. So it is called orphan drug because it has to be supported by government authorities. So it has to be maximum support is from US government for this drug. So it is called orphan drug. There are other orphan drugs also, but Mavacamten, according to our topic, launched in India in October 2025. So mechanism of action is like we see in the normal sarcomere, the first image. There is actin myosin bridges and normal contractility with effective relaxation. The normal myosin bridges, the number of myosin bridges in a normal sarcomere. In HCM, the number of actin myosin bridges are more. So there is more aggressive contraction, hypertrophy of the muscle. Now what does the Mavacamten does? It decreases the hypercontractility. It increases the super relaxed state of the myosin linking bridges. So there are a lot of myosin bridges, but they become inactive because of the Mavacamten. So this drug reduces the ejection fraction of the patient. So patient may develop hypotension, 60 to 65% of EF in follow-up will become 45 to 50%. But that decreases the symptoms also. It decreases the aggressive contraction of the sarcomere. So increase the proportion of myosin heads in SRX states, that is the super relaxed state. Now, Camzyos is the name of the drug, Mavacamten. So this is the follow-up recommended by American Heart Association. Before treatment starts, then at 4 weeks you have to again do the echo, at 8 weeks, 12 weeks and every 12 weeks after that for Mavacamten. So accordingly for beta blockers, maybe we should follow that. I am not aware of the actual data, but we can follow accordingly. So when to intervene? When medical therapy fails or even after medical therapy